Assalamu alaikum. So today, inshallah, we'll be talking about quite an interesting topic. We'll be talking about echocardiography, but not as to teach you echo. It's as get you familiar if you know surgical anatomy, and then we will get to know surgical anatomy as we go through. So it does make a big difference to actually be knowing anatomy when you're looking at echo views. And on the other hand, it goes both ways. If you're a surgeon, it makes a whole difference if you correlate what you see on echo view with what you see actually inside the operating theater. So I am a surgeon, so don't take everything I said as for granted, okay? So we'll essentially be going through a very quick overview of basic cardiac surgical anatomy, quickly through different chambers and valves. And then we try to correlate what we see in anatomy with what we see on echo. And then we give some examples so that we do something more practical for different congenital lesions. So this is a cast for the heart. Essentially, we're looking as if we're looking from the front and slightly above. So you can see SVC, IVC, right atrium, right ventricle, pulmonary, and then pulmonary veins at the back. We almost can't see them just from here. Then left atrium again at the back, you can see the left atrial appendage from here. Then to the left ventricle, where you can just see the apex. And then the left ventricle will empty into the aorta. And then you can see that the right ventricle is an anterior structure. So it's more anterior and to the right of the left ventricle. On the other hand, it needs to go to the pulmonary bifurcation, which is posterior and to the left, as opposed to the left ventricle, which is posterior to the left, that needs to go to the ascending aorta, which is eventually anterior to the pulmonary bifurcation and slightly to the right. And so, to be able to do that, the outflow tracts need to cross each other. So if this is the plane of the right ventricular outflow tract, that would be the direction of the left ventricular outflow tract. So they normally cross each other nearly at right angle. Again, this has a lot of implication while seeing these structures. So this is the anatomy of the right atrium. So now we're looking as if we're looking from the right side, reflecting the free wall of the right atrium and looking to the RA cavity, right atrial cavity. So this is atrial septum, and you can see fossa ovalis, SVC, IVC, Eustachian valve, which is not a true valve, it's just like a fibrous flap. And this is the tricuspid valve opening into the right ventricle. You can see that the right atrium has a big right atrial appendage with pectinate muscles that go across the right atrial appendage into the body of the right atrium, all the way to the crux of the heart. You cannot just point at a point and then say this is the neck of the right atrial appendage. The right atrial appendage is wide and broad-based and just merges into the body of the atrium, as opposed to the left atrial appendage. This is the fossa ovalis, which is the actual true atrial septum. On the other hand, the muscle around them is more like of the wall of the right atrium and left atrium folding to form this muscular part of the atrial septum. And so if you pass a needle across that, you go right atrium, outside of the heart, extracardiac fat, then you go into the left atrium again. Well, this is actually just a fibrous flap. You just go from right atrium to left atrium directly. So here would be SA node, which is at the junction of the SVC to the right atrium at the cresta terminalis. And here would be the triangle of Koch. bound by ostium of the coronary sinus, septal leaflet of the tricuspid valve, tendon of Todaro. The apex of that would be the site of the AV node, which immediately anterior to it is the membranous septum, where you get the conduction bundle of His and bundle branches going into the ventricle. So this is the shape of the right atrial appendage from outside, and this is the anatomical view of the right atrium. So fossa ovalis, crista terminalis, right ventricle through the tricuspid valve. This is triangular Koch. On the other hand, if you look at the left atrial cavity, it's small of smooth walls, so no pectorate muscles, just very confined to the appendage, which actually has a very well-defined neck that shows us where is appendage and where is body of the left atrium. The right ventricle has 3 parts, so inlet, apical trabecular part, and outlet. The inlet is bound by the area from the tricuspid annulus into the chordal attachment of the tricuspid valve. What is beyond that is apex, and above the medial papillary muscle is the outlet. So we call that right ventricular outflow tract, conus infundibulum. And then we've got 3 papillary muscles, so anterior, medial, and posterior. And the tricuspid valve has got 3 cusps, so the anterior, posterior, and septal. Where would the left ventricular outflow tract be in this diagram? LVOT, so it would be posterior, but in that direction, crossing the right ventricle. And so the aortic valve would be here, so as if it is in a perpendicular axis to the pulmonary valve. Okay? So this is a specimen view showing the cavity of the right ventricle. So this is ventricular septum. Here is inlet, apical trabecular part, and outlet. This is tricuspid valve, and here is the pulmonary valve. And then you would expect that aortic valve would be at that level. Can you notice the coarse trabeculation of the RV cavity? On the other hand, the left ventricle also has 3 parts, so inlet, apical trabecular part, and outlet. But then the trabeculation in the left ventricle are fine and crisscross, so like that. Also, there's an important thing here. There's a continuity between the mitral valve and the aortic valve, which is not there between the tricuspid and the pulmonary. So there's a big gap between the tricuspid and pulmonary, where actually the LVOT would be here, separating between at the back, behind that septum, between the tricuspid valve and pulmonary valve. Then quickly looking at valves. So this is a surgeon view of the mitral valve. So if we're looking from the left atrium into the surface of the mitral valve, the atrial surface, if this here is aorta, and this is atrial septum, that's the lateral wall of the atrium, so the appendage would be here. So we call that anterior leaflet and posterior leaflet. So the anterior leaflet has large area, but is attached to a smaller part of the circumference, while the posterior leaflet has much smaller area, but is attached to a much wider part of the circumference. And you call that scallops, P1, P2, P3, so P is posterior, and then you've got indentation here separating different scallops, P1, P2, P3, and then the corresponding areas at the anterior leaflet is A1, A2, A3. The mitral valve has a saddle shape, so normally the anterior and posterior parts of the annulus are higher than the sides. So this is a specimen showing the mitral valve and a 3D echo view showing the same picture with different scallops. Then let's look at the mitral valve from the ventricular surface. So if we look here, this is as if we're having a cut section in the left ventricle and looking from below. Then you can see that the mitral valve has got anterior leaflet, posterior leaflet. You can see both papillary muscles, the anterolateral and posteromedial. And then you can see this is the aortic valve. So here is left ventricular outflow tract, LVOT, and you can appreciate the aortomitral continuity. Okay? You can notice here that the mitral valve is not attached to the ventricular septum. So the mitral valve does not have septal attachment, as opposed to the tricuspid valve, which is attached to the septum. Okay? Then looking at semilunar valves, so like aortic and pulmonary valves, then you can see that the design of this valve is very different from mitral and tricuspid, where in the mitral and tricuspid you need cords pulling the leaflet into the ventricle. While here, it's a semilunar valve with 3 cusps, and these cusps are attached at higher areas called the commissures, and then they coapt together with the blood without having any cords. So this is a systolic view, and this is the diastolic view with the valve closing. And the aortic valve, the aortic root has the coronaries. So this is a cut section in the base of the heart. So as if we're taking out the atria and great arteries and looking from above. So this is anterior, posterior, right and left. This is mitral valve, tricuspid valve, aortic valve, and pulmonary valve. So here we can appreciate the aortomitral continuity, which is not there between the tricuspid and the pulmonary. So the tricuspid and pulmonary are actually separated by the LVOT in between. So the plane of the ventricular septum would be like here. Okay? Also, you can see normally the pulmonary valve is anterior to the aortic valve, but also slightly to the left. So normally the pulmonary valve is anterior and to the left of the aortic valve, but they're also not in that same plane. So the pulmonary valve is going like that, while aortic valve is heading like this. So they're at different planes. So normally if you get short axis in one route, you get it as the long axis in the other route. You can see here coronary arteries. So this is the right coronary artery going in the right AV groove, left coronary artery giving LAD and circumflex. So let's talk echo. So like the CT, where you get cut sections, and then you call that in the CT like axial, coronal, sagittal. In the echo, you also take cut sections, but since the probe is, you can control where to look from, you just get cut sections in the heart at different areas, and then you call that echo window. So parasternal, subcostal, apical, and suprasternal. So do you remember this picture? We're just looking at the heart, looking into the RV cavity. So let's assume we take a cut section in that plane. So a cut section going across the base of the heart, going from the tricuspid valve into the pulmonary valve. So if this is the heart, and then you cut in that plane. Then we look from below. It looks like a weird cut section. But then, so if you're looking from below, you can see a tricuspid valve at one side, pulmonary valve at the other side. We've agreed that the aortic valve would be at that plane, here. And then you can see left atrium and right atrium with interatrial septum in between. This is exactly the parasternal short axis view of echo. So if this is the aortic valve looking from below, Here's aortic valve. Right atrium, atrial septum, left atrium. They are here. This is the tricuspid valve, and you see a very small portion of the RV inlet. So you cannot see here any parts of the body of the right ventricle because it is in the part that was removed. We're just looking to a very limited part of the RV inlet. And then you can see the pulmonary valve, which is at a different plane. So this is long axis, while the aorta is the short axis. Now you can see the RV inlet and the RV outlet with the aortic valve, short axis, and pulmonary valve here. So this is the parasternal short axis view of echo. So let's try to go lower from base towards apex. Before doing that, how would you call the cusps of the aortic valve? So right coronary, left coronary, and non-coronary. Because you have to appreciate that in transthoracic and transesophageal echo, and you look from different directions. So wherever you look from, the cusp that is related to the interatrial septum is the non-coronary cusp. The cusp is that is toward the front of the patient is the right coronary, and the third one is the left. Okay, because if you look from transthoracic, you look from the front, and then the right coronary cusp will be towards the probe. While if you look from the transesophageal echo, you look from the back, and then the anterior cusp would be away from the probe. So the cusp towards the atrial septum is the non. The one in the front, towards the front of the patient is the right, and the third one is the left. So now we go lower at a lower cut. So now we cut at the level of the ventricles, and you can see the tips of the mitral valve. You can appreciate here that the LV is thick-walled as opposed to the right ventricle, which is much thinner-walled. Also, you can see that the LV contour is like a circle, while the RV is like a crescent around it, because the septum normally goes towards the right because of the higher pressure in the left ventricle. How would you call these walls? So if we're looking from here, so this would be anterior, inferior, septum, and lateral wall. And so if you want to comment on regional wall motion abnormalities, looking at that view, you can see that this is anterior towards the LAD, and this is inferior, septum, and lateral wall. So that is the short axis view at the level of the mitral valve. And then at the tips here, you can actually measure mitral valve area. Where would you find the LVOT here? So LVOT is related to the anterior mitral leaflet. So if I put my finger here, I will actually go through the aortic valve. Okay? So this is LVOT. And now if we go further down, you can see different papillary muscles. So anterolateral, posteromedial papillary muscles. Now, let's go further up, even higher than the level of the roots. So this is a cut section into the pulmonary artery, pulmonary bifurcation, and the ascending aorta. So the aortic valve is still low down. So this is a similar view, but just the reverse, okay? As if we're looking from above and from below. So you can see the ascending aorta as a circle, a short axis, but then the MPA bifurcating into RPA and LPA. So the artery that goes behind the ascending aorta, behind the SVC, is the RPA, the right pulmonary artery, while the other one is the left pulmonary artery. So you can see it here. So this is pulmonary valve in long axis, RVOT, then main pulmonary artery. The one that goes behind the ascending aorta is the RPA. The other one is the LP. So let's flip the cut and then cut across the left ventricle in a longitudinal manner. And you get this cut section. So now we're cutting, remember, the right ventricle outflow tract is crossing the left ventricle outflow tract. So if you cut at the long axis of the left ventricle, you cut the right ventricle as a short axis, and so you get the RVOT as a circle here, because you're cutting as a short axis in this structure. So this is left atrium, mitral valve, left ventricle, LVOT, ascending aorta. This is the parasternal long axis view of echo. Exactly the same, left atrium, left ventricle, LVOT, ascending aorta, and this is RVOT in short axis. And then you can see that this is the anterior mitral leaflet here. This is the posterior mitral leaflet there. And there's aortomitral continuity. This is the parasternal long axis view.
What is the aortomitral continuity?
Here. So you can see that this is the anterior mitral leaflet, and it gets attached into the aortic valve without muscle in between. So this is muscle.
Yeah.
You do not get this thick muscle here. So in some diseases where you get the double conus, you can actually see a muscle intervening between whatever root is here and the mitral valve. Normally you do not get that. So this is anterior mitral leaflet, and this is the aortic valve, and there's no muscle here. Okay, this is a bit difficult. Now you take this cut section and you cut across right atrium and right ventricle with a tricuspid valve in between. And you get this specimen where you have got right atrium, tricuspid valve, right ventricle. You're just taking a thin slice. So if you cut this, look there, you see tricuspid valve between right atrium, right ventricle. This is the RV inflow. And then you can see you align well at the tricuspid valve, and then you can see tricuspid regurg, and you get you can align Doppler flow there. On the other hand, if you flip your cut at the axis of the RV outflow, so this is cutting the RV inflow. If you move that into RV outflow, where you go from RV body across the RVOT towards the pulmonary valve, you get this. So this is RV outflow view. So this cut section is going across the right ventricle, RVOT pulmonary valve, and since that is in the long axis, you get the LV as short axis. So this is RV outflow view. And then again, you can align here very well towards the pulmonary valve. You can get gradient measure Doppler here. Okay, so this is RV outflow view. Now, what if we cut across both atria and ventricles in that plane? So this plane. Okay, so you cut across both atria and both ventricles, and then you get a 4-chamber specimen. Right atrium, this is the orifice of the IVC, looking below. This is tricuspid valve, right ventricle, left atrium, mitral valve, and left ventricle. This is the apical 4-chamber view of echo. And then you can see that the mitral valve is attached at a higher plane than the tricuspid valve. So the tricuspid valve is more towards the apex than the mitral valve. And this is known. And now if you start moving this plane towards anterior and posterior, you get this. So if you go more anterior, you go towards the aorta, and then you get the 5-chamber view, where you get right atrium, right ventricle, left atrium, left ventricle, but also you get LVOT and aorta. Okay? So this is apical 5-chamber view. Again, you align well on the LVOT, and you can measure a good Doppler signal here. On the other hand, if you go very posterior, you go towards the coronary sinus, and then you can find the coronary sinus behind the left atrium in the left AV groove. So you can get the coronal sinus here. So this is the variance from the 4-chamber view, anteriorly and posteriorly. So again, this is an apical view, which is very similar to the parasternal long axis. So instead of just putting the probe parasternally and you cut the left ventricle at its long axis, you cut the same plane but from towards the apex. So you get left atrium, mitral valve, left ventricle, LVOT, ascending aorta, and this is the RVOT in like short axis. So this is apical 3-chamber view, where you get left atrium, left ventricle, and aorta. But then if you move your cut section so that it does not get the aortic valve, only get left atrium and left ventricle away from the LVT and aorta, you get the apical 2-chamber view. So this is left atrium, left ventricle, left atrium, left ventricle, and then you cut the anterior wall and inferior wall in the apical 2-chamber view. So let's cut a big cut section across the whole aorta. So ascending arch, descending aorta. How would you get that on echo? With a suprasternal view, and then you align towards the aorta. And then you can see this is aortic root, ascending aorta. The artery that passes behind the ascending aorta is the right pulmonary artery, the RPA. You can see very well the aortic arch. If you get a narrowing at the distal arch, like a coarctation, you can appreciate that here, and the descending aorta. And what is just below the RPA is the left atrium. So this is left atrium. Here is a subcostal view, which is very similar to the apical 4-chamber. And then you can get also that, but you can appreciate that the probe is coming from the subcostal, where the first thing you see in the view is the liver. So that's a 4-chamber view, but from the subcostal window.
Could you repeat the previous image?
Yeah. So that's a suprasternal cut, and then you align the probe so that you cut along the aorta. So you get the ascending arch and descending aorta.
Branches?
The branches. So the first branch would be the brachiocephalic, then common carotid, and subclavian. So you get 3 branches, and depending on the direction of the brachiocephalic, is it right towards the right or left, the arch would be on the opposite direction. So brachiocephalic towards the right, then it's a left arch. And then you can see very well here the coarctation, but you can also see flow reversal in aortic regurg and things like that. Do you remember this picture? Looking at the right atrium, right atrial cavity, this is the atrial septum. So let's assume we get a cut section here, passing through the SVC, atrial septum, IVC, and then look from the back. You get this. So this is SVC, atrial septum, IVC. You remember the folding of the walls of the atria. This is the fossa ovalis. So here is right atrium, while here is left atrium. We're looking from the back. So if you put this picture like that, you get the bicaval view of the transvisual echo. So this is, you remember the esophagus is just behind the left atrium. So the first thing you see is the left atrium, then atrial septum, SVC, IVC, eustachian valve, right atrium, and appendage. So this is the bicaval view of transvisual echo. So let's do interesting things. Are you still with me? Do you want me to repeat anything, anatomy or echo? Let's try to guess the places of the VSDs. So what is a perimembranous VSD? That's the VSD where part of the edge of the defect is tricuspid annulus and aortic annulus. Okay. Where is the aortic annulus here? Here. So this is tricuspid valve. Now we're looking at the RV cavity. This is ventricular septum, tricuspid valve, pulmonary valve, and the LVOT is in that direction. Aortic valve is at that plane. Where would you find a VSD where part of the edge of the defect is the tricuspid annulus and aortic annulus? Here. So this is perimembranous VSD. So if you get a cut section here, tricuspid valve, aortic valve, the VSD would be in that direction, which is on short axis view would be at that area, where you cannot find any muscle septum formed between the tricuspid and aortic valve. So you get here perimembranous VSD. So this is a perimembranous VSD. So this is the defect. This is ventricular septum, tricuspid valve, pulmonary valve. Here you can see aortic valve, and then part of the edge has no muscle. It's formed between the tricuspid annulus and the aortic annulus. So this is a perimembranous VSD. Where would you find the subarterial VSD? Pulmonary and aortic valves. So in that diagram, it would be here. So part of the edge of the defect is formed by the aortic annulus and pulmonary annulus. So in this cut section, it would be towards the pulmonary annulus, which is there in echo. This one. So now part of the edge of the defect is formed between aortic annulus and pulmonary annulus. So this is pulmonary valve, this is aortic valve. Here is the defect, and this is a subarterial VSD. Tricuspid valve is still low down. Yeah? So you'd find it that way. What if you have an outlet muscular VSD? So where is outlet? Anything above the medial papillary muscle, you consider that an outlet. What is a muscular VSD? Is a VSD that's surrounded by muscle all around from the right ventricle side. Okay? So to be here, so it does not reach the tricuspid valve, does not reach the pulmonary valve. This is the place of the outlet muscular VSD. And then here you would find it in the middle between the tricuspid valve and the pulmonary valve. It does not reach the tricuspid valve annulus, nor the pulmonary valve annulus, while just below the aorta. So it would be there, and then you can still find septum towards the tricuspid and septum towards the pulmonary. So this is an outlet muscular VSD. Here tricuspid valve, pulmonary valve still high up. This is aortic valve, and then there's muscle all around. So that's an outlet muscular VSD. So what if you have a VSD that is shown on echo here? So for a surgeon looking through the tricuspid valve, where should he look for this VSD? Let me tell you, sometimes it is difficult to find VSDs because they can be hidden below the thick trabeculation of the right ventricle. So you have to have a plan when looking for VSDs. So if there's a relatively small VSD that is hidden behind trabeculation, and then you can see on echo that there's a jet or a defect at that part. So where would you look? So now, is that anterior or towards inferior? So you remember we said that this is anterior wall, this is inferior wall, here is septum, and this is lateral wall. Is that towards anterior or towards inferior? Inferior. So inferior is towards the diaphragm. So if I look through tricuspid valve, I should be looking towards the diaphragmatic surface of the right ventricle. It would be here. So that would be an inlet muscular VSD towards inferior. Okay? It makes a whole difference if you can correlate echo view to what you see inside the operation, And on the other hand, if echocardiographers, cardiologists, and anesthetists can actually correlate with anatomy. Okay, what if you have an inlet VSD? So this is a canal type VSD. So this is a complete canal, right atrium, right ventricle, left atrium, left ventricle. And then you would find the VSD, the canal VSD is an inlet VSD. Where do you see the RV inlet? So if you look in the parasternal short axis view, remember here, this is parasternal short axis view. Where is the ventricular inlet? Here. So this cut section does not show the ventricular inlet. Does not show anything in the mid-septum or the apex. So if you need to look at the inlet, mid-muscular, or apex, you need to get the four-chamber view, the other axis. So you would look at something that cuts in that plane, where then you can show inlet and apex. Okay, so in inlet VSDs, like the canal types, you actually have to look for four-chamber view and not short axis view, not other views. Okay. So these were examples for VSDs and how to use echo to differentiate and correlate that with surgery. Other interesting things is the conal septum deviation. So what is the conal septum? It is the septum that separates between LVOT and RVOT. Wrong. Okay. It is actually the septum that separates between the inflow of the aortic root and inflow of the pulmonary root, which seems to be the same, but they're different. Because what if the patient has double outlet right ventricle, and then the whole roots come out from the right ventricle? The conal septum will follow the roots, while the LV outflow is the VSD. So this is totally not related to the roots. Do you get that? Anyway, so conal septum is the septum that separates the inflow of the aortic root and pulmonary root. This can be deviated anteriorly to cause tetralogy of Fallot, or posteriorly to cause LVOT obstruction, sometimes associated with arch anomalies. So this is the part of the conal septum. So it was supposed to be here, separating between the aortic inflow and pulmonary inflow. And now it is deviated anteriorly. So now it goes into the RV cavity. So this is the conal septum, and this is the rest of the muscular septum. So this anterior deviation resulted in a VSD, because now this has left its place and creating a communication between the left ventricle and right ventricle. So this is a VSD. Now, since this was deviated anteriorly, it has pulled the root that was behind it, which is the aortic root. And now you get overriding aorta. This anterior deviation has met the free wall of the right ventricle, causing obstruction in the pulmonary inflow. So you get pulmonary stenosis. And as a result, you get the RV hypertrophy. So this is a tetralogy of Fallot, with anterior deviation of the conal septum, VSD, overriding aorta, RVT obstruction, and RV hypertrophy. So tricuspid valve, pulmonary valve, VSD, deviated conal septum, this is aorta, and this is pulmonary. That's exactly this same view. Tricuspid valve, pulmonary valve, conal septum should have been here. Now anteriorly deviated, creating a VSD, overriding aorta, RVT obstruction, RV hypertrophy. So this is a tetralogy of Fallot with a Fallot view. You can have a malalignment VSD, which is very similar but without actually causing RVT obstruction. So this anterior malalignment was not severe enough to reach the free wall of the right ventricle, and so the VSD and overriding aorta are still there, but there's no pulmonary stenosis. And then again, you get the same view here. So this is the VSD with the anterior deviated conal septum. This is aorta above the RV, but also the RVOT. And now what if this conal septum has deviated posteriorly towards the left ventricle? So this is a parasternal long axis view. Left atrium, mitral, left ventricle. This is ascending aorta. This is the conal septum, should have been here. And now this is deviated posteriorly, causing a VSD, but also narrowing of the LVOT. So this is LVOT obstruction caused by posterior deviation of the conal septum, which you can see here. So this is the conal septum, should have been there. This is the LVOT, and now this has deviated posteriorly towards the LV, causing LVOT obstruction and the VSD. If you find the posterior deviation of the conal septum causing LVOT obstruction, you have to search for arch hypoplasia or interrupted aortic arch. Again, the blood going here is much less. Now let's go through outflow tracts. We've mentioned normally outflow tracts cross each other. So if you see one valve as a short axis, the other valve should be in a long axis. Till you get TGA, where the outflow tracts do not cross each other. So if this right ventricle gets connected to the aorta, just in front of it, while the posterior ventricle connects to the pulmonary artery, so they do not need to cross each other. So they are parallel, and then you can see them parallel to each other. This is the TGA. In this case, that's a DTGA. And then you can find them both at long axis or both at short axis. So this is TGA. So just to conclude, always correlate echo views with surgical anatomy. It makes a huge difference for echocardiographers, surgeons, anesthetists, radiologists, and whoever. If you know anatomy, you already know echo. You just didn't know that you know. Obviously, echo is not just that. It gives you a good start. And heart team approach makes a whole difference with surgeons, cardiologists, anesthetists, radiologists sitting together and each giving their own perspective. Any questions? Thank you.